Systemic lupus erythematosus is an autoimmune complex or disease that is categorized as a type 3 hypersensitivity. It's a condition where the body attacks itself. The organs that are most likely affected are the skin, joints, serosal membranes. It can be acute or it can be insidious. There are clinical presentations, but they can vary, and there is a criteria for diagnosis. There is a criteria for diagnosing lupus, which I'm relating to the case study. The symptoms would be a malar rash, a disc-cold rash, photosensitivity, oral ulcers, arthritis, serositis, proteinuria, neurologic disorders such as seizures, psychosis, hematologic disorders that can include leukopenia, lymphopenia, thrombocytopenia, anti-DNA antibody to native DNA, anti-SM, um, and immunologic disorders such as the positive VDRL but yet negative for the organism. This patient presents with a few of those are positive. She does have the joint swelling. She has pleuritic chest pain. She also has a pleural effusion, um, swelling of her hands, feet, and knees. Um, Enlarged cervical and inguinal lymph nodes, and hemoglobin was a little on the low side, but not overly so. Her UA was positive 4 plus proteinuria with white blood cells, red blood cells, and red cell casts in the urine sediment. She did have a positive VDRL, but she tested negative for the actual organism. BUN and creatinine were just slightly elevated. It seems she responded favorably to the prednisone given, where she almost returned to normal. Um, so I would say that it's very likely this patient has lupus. The article I'm critiquing addressed the symptoms of lupus and the possible genetic predisposition involved. It also was talking about the role that complement may play in the progression of the disease, um, or how it affects the disease. It seems that it's useful uh, before the actual disease happens, but once um, it takes its course, complement can actually exacerbate it. This was a very informative article. However, I don't think that some of the correlations were strong enough, especially with the complements. There is a strong correlation with the C1q deficiency, but that is so rare that it's not pertinent to most of the lupus cases. So overall, I would say it did provide information. My article for this week, 6/6/2015. I'm having trouble uploading my other slides, but I just wanted to make sure I post it. Anyhow, the article was in regards to lupus again, so it dealt with targeting interferons in systemic lupus erythematosus, current and future prospects is the name of the article. And basically, what they're trying to do is we know that interferon plays a big part in lupus and in autoimmunity. So the increased signal of the interferon pathway um, initiates or sustains autoimmunity. Um, so if they could find something to uh, block that pathway, then you block the interferons, and then you're not going to have such a strong autoimmune response. So the idea is they were using drugs that are actually being tested, but one of them is sifalisumab, and what it does is the agents target the pathway, so it's a passive immunization with therapeutic monoclonal neutralizing antibodies and is the first method in trying to reduce the levels of interferon. So basically, they seem to be having good results. It's not all conclusive yet, but they were testing different drugs, not just that one. Lupus mesenteric vasculitis is a life-threatening condition that can happen when a person has lupus. It's not a common occurrence, however, since it's very serious, it's important to address it. This case presents a 48-year-old African American female. She comes in initially with flu-like symptoms. Um, she hasn't had an exacerbation of lupus within the last 10 years, so basically she's been in remission. There's a history of hypertension, TB, chronic renal insufficiency, surgical history. She's had a vascular necrosis of the femoral head due to the use of steroids. Comes into the ER with a blood pressure of 70 palpable and a heart rate of 122. She's given fluids which somewhat improve the condition. However, 4 days after admission, she develops a generalized colic, abdominal pain with a feeling of needing to pass flatus. The abdomen gets distended and tender. There's no guarding or rebound tenderness. And there is no blood in her stool either. The CT scan, however, does show mucosal thickening and edema of the bowel wall with concentric halus and appearance of a target. There's large ascites and bilateral pleural effusions. On superior mesenteric angiograms shows that there's shunting of the contrast material from the mesenteric arterioles directly to the venous system. In other words, it's bypassing the capillary system. This is showing that there is lupus mesenteric vasculitis, and the treatment is high doses of steroids, which after 3 days of treatment, the abdominal symptoms subsided. The vasculitis is probably due to occlusion caused by the deposition of immune complexes within the vessels. So I just thought it was an informative article and an interesting case. This voice thread is replaced by the one for 6/6/2015, since I didn't have the slides at the time. This is a study. Studies are being done targeting interferons in systemic lupus erythematosus. And basically, interferons are a family of glycoproteins. They're produced by cells in response to pathogens. They differ in their protein sequences, receptors, and then the type of cells that produce them. However, they usually correlate to disease activity and severity in lupus. Therefore, it's interesting and would be good if the interference could be blocked, and this is what this study is about. Um, some of the agents that are being used, it's sifalisumab and Medi 545, and what they're trying to do is targeting the interferon pathway. In turn, this would decrease the body's response. It's a passive immunization with therapeutic monoclonal neutralizing antibodies. It's the first method of reducing the levels of interferon, and they are obtaining effective results. We know that the autoimmune response of lupus is a disease that can affect multiple systems, specifically the kidneys. We know that kidney involvement is usually present. Patients with lupus have increased risk of developing progressive renal failure, which can require renal replacement therapy. We also know that up to 50% of systemic lupus erythematosus patients have significant renal involvement, including many forms of glomerulonephritis with inflammation and fibrotic components. The treatment is usually with corticosteroids and immunosuppression, which these treatments are not without risk. They lead to an increased risk of morbidity and mortality. The study I looked at is dealing with lupus nephritis. It includes many forms of glomerulonephritis with inflammatory and fibrotic components. The study dealt with the high collagen 1 gene expression and using it as an independent predictor of adverse renal outcomes in lupus nephritis patients with preserved renal function. Specifically, the glomerular filtration rate, the patients that they used for the study had to have a normal GFR, and the objective of the test was to test a correlation between renal fibrogenic genes and renal fibrosis at the time of the renal biopsy and its prediction of renal outcomes. The renal gene expression of transforming growth factor and collagen 1 were studied by real-time multiplex quantitative polymerase chain reaction. The conclusion of the study was that a high collagen 1 messenger RNA expression was an independent predictor of renal outcome in patients with preserved glomerular filtration rate. This is important because we want to be able to determine or predict whether someone has a higher degree of losing renal function, and at the same time that way they can be treated accordingly before we get to that point. And it was a study by several scientists. It was conducted in Thailand, and it seems like it was something worthwhile. This article is addressing the relationship between nitric oxide and oxidized LDL levels in systemic lupus erythematosus patients. We know that nitric oxide is a chemical that's generated by endothelial cells, by macrophages, neurons, and other cells. We know that oxidized LDL is a result of synthesis of triglycerides in the liver and cleared by LDL scavenger receptors. In this article, the study is investigating the relationship between these two and in an attempt to predict the damage on blood vessels by atherosclerosis. The plasma nitric oxide was significantly higher in SLE patients, and the oxidative LDL plasma levels were lower in SLE patients. However, after further study, it was found that that the excess nitric oxide prevents oxidation of LDL particles, so that the inflammatory events in comparison to the oxidative modifications may be most involved in clinical complications of SLE patients. In other words, there was no correlation. Rather, it's more of an inflammatory process that's causing the damage, not so much the relationship between the nitric oxide and LDL, oxidative LDL.